Thank you for watching my video. My name is Sam Rooney and this is a case study on a complete T4 spinal cord lesion. Peter is a 28-year-old paraplegic who suffered a complete spinal cord lesion at the T4 level when he had a motor vehicle accident at the age of 19. He was an athletic volleyball player before the accident. He is wheelchair bound but independent for all other activities of daily living, including bowel and bladder movements, and he drives with hand controls. He now works in IT and lives a sedentary lifestyle. Peter's clinical presentations are a BMI of 32.5 with a stable weight, blood pressure of 105/63 with a resting heart rate of 85. He has normal sinus rhythm with the normal heart, lung and bowel sounds. His skin remains intact and has a mild loss of shoulder extension, internal and external rotation, and mild pain when he lifts his right arm in the sagittal plane. This study will look at Peter's hyperreflexia responses, the cardiorespiratory changes associated with spinal cord injury, future complications that Peter may experience, his BMI, and how his autonomic dysreflexia can be managed. So what is hyperreflexia? Hyperreflexia, or autonomic dysreflexia, is an acute syndrome of uncontrolled sympathetic hyperactivity in spinal cord injury patients, which can have serious consequences if untreated. It is caused by excitatory spinal reflex responses which remain intact, regardless of spinal cord injury. In short, when the body detects a noxious stimulus below the level of injury, a sympathetic response causes a protective reaction and vasoconstriction. In a healthy person without spinal cord injury, inhibitory responses will be sent down the spinal cord in order to modulate the sympathetic action. Given that these pathways are disrupted in patients with spinal cord injury, these messages are ineffective and result in an uncontrolled and excessive sympathetic response. It is this inability to moderate sympathetic responses that cause the signs and symptoms associated with Peter's overfull bladder and tendon tap. A tendon tap is used to initiate a stretch reflex in the muscle spindle. When a muscle spindle detects a change in muscle length, it sends impulses to the spinal cord. These impulses are sent via sensory neurons, which synapse with motor neurons at the spinal cord level and return to the muscle fibers, initiating a contraction response. This reflex circuit operates independent of higher centres and such is still able to function in patients with a complete T4 lesion and explains Peter's brisk reflex response at the knees and ankles regardless of his 0 out of 5 lower extremity motor strength score. Loyorosol is a muscle relaxant and antispastic drug which is used particularly in patients who suffer from spasms in the flexor muscles. It reduces the excitability of reflex action systems and therefore reduces episodes of spasticity. It works through inhibiting monosynaptic messages at the spinal cord level, which inhibits the transfer of messages from the sensory to motor neurons. Peter intermittently notes pounding, headaches and sweating associated with an overfull bladder, which is caused by autonomic dysreflexia. Spinal cord injuries at T6 and above lack awareness of bladder filling, and it is this lack of awareness that leads to overfilling of the bladder and associated autonomic dysreflexia. The visceral distension caused by an overfull bladder produces hypertension in the patient. In autonomic dysreflexia, hypertension ranges from a mild 20 mm of mercury above baseline to a severe 240/120 or even higher. In response to the hypertension caused by visceral distension, a baroreflex response causes vasodilation above the level of spinal cord injury in an attempt to reduce blood pressure. This vasodilation is what causes headaches and sweating above the level of injury. Peter takes Detrol to control his bladder spasms. It is a type of tolterodone tartrate, which is an antimuscarinic agent. Antimuscarinic agents work by inhibiting muscarinic receptors in the detrusor muscle, which when stimulated leads to bladder contraction and voiding. It is recommended that these pharmacologic interventions be accompanied with a timed bladder voiding plan. This will help to avoid excessive bladder filling and the associated autonomic dysreflexic response. Let's now look at Peter's relatively low resting blood pressure and what other cardiorespiratory changes may be present. Peter has a baseline blood pressure of 105/63 and a resting heart rate of 85. Cardiovascular disorders are common in spinal cord injury patients and account for a large amount of deaths. In patients with spinal cord injuries, hypertension is caused through a loss of systemic vasomotor tone. This produces vasodilation and increased venous capacity. Add to this a loss of muscle tone in the lower limbs, and the lack of venous return creates blood pooling and reduced blood pressure. Heart rate and blood pressure are controlled by the sympathetic and parasympathetic nervous systems. The sympathetic system is excitable and increases heart rate, force of myocardial contraction, and peripheral vascular resistance. which can produce an increase in blood pressure. The parasympathetic system is responsible for reducing the heart rate and generally is most active during rest. It is controlled through the vagus nerve, which is unaffected in most spinal cord injuries, including Peter's. So the excitable sympathetic nervous system increases blood pressure and the parasympathetic system reduces it. A spinal cord injury causes disruption to the descending spinal pathways, including the sympathetic nervous system. This results in a disrupted sympathetic pathway and the reduced blood pressure seen in spinal cord injury patients. The increased venous capacity and blood pooling causes a reduction in blood pressure through reduced venous return and therefore decreased ventricular filling. This causes a decrease in preload and a reduced stroke volume. To compensate, the heart rate is increased to maintain adequate cardiac output. Spinal cord injuries often cause other changes in cardiorespiratory function, and these vary depending on level of injury. There is no specific changes at each level of the thoracic spine. However, the intercostal muscles are innervated through the thoracic vertebra 1 through 7, and injury to these areas will cause varying levels of cardiorespiratory dysfunction. The intercostal muscles control the elevation of the rib cage and are important in the function of deep breathing and coughing. A complete injury at the T4 level will also affect the abdominal muscles, which are innervated through T6 to T12 and assist in oxygen expiration. These functional deficits will affect the quality of breathing, which has a direct influence on the body's ability to effectively oxygenate tissues and expel carbon dioxide. The affected ability to cough also causes the inability to mobilize secretions and can cause congestions. These factors can cause fatigue in patients and would be a contributing factor to Peter's reported excessive fatigue. Given that Peter's injury is at the T4 level, he will still have some limited control over intercostal muscles, and part of the maintenance therapy is to train these muscles to strengthen them for mobilization of secretion and ventilation control. A secondary effect of paraplegia is the decline in cardiorespiratory function associated with reduced activity. Many paraplegics are found to have low levels of cardiorespiratory fitness, and normal wheelchair use does not appear to have much of an effect on fitness levels. Reports have shown paraplegics to be on the lowest end of the human fitness spectrum, and that 25% of otherwise healthy young paraplegics had an upper extremity VO2 max, which was only just sufficient to maintain independent living. It would be beneficial for paraplegics to participate in specific activities to improve cardiorespiratory function, such as arm crank training or other methods of cross-training. Let's now look at what complications Peter may experience in the future as a result of his injuries. Complications in patients suffering from spinal cord injuries are a frequent cause of morbidity and mortality and can lead to increased rates of rehospitalisation, increased healthcare costs, a loss of employability and decreased quality of life. Common complications in spinal cord injury patients include autonomic dysreflexia, pressure ulcers, osteoporosis or fractures in the lower limb, and thromboembolic diseases. As discussed earlier, autonomic dysreflexia or hyperreflexia is triggered by a noxious stimulus and causes a sympathetic reflex response, which is uncontrolled due to a disruption in descending spinal pathways. The presentation and treatment of autonomic dysreflexia in Peter's case will be covered further in detail later in this presentation. Pressure ulcers are caused by constant pressure and friction on the skin. They can be difficult to treat, and paraplegics are at risk of developing them due to their lower limb immobility. Peter can reduce the risks of developing pressure ulcers through regular position changes, good skin care and hygiene, and through a healthy diet. Osteoporosis or lower limb fractures are also a future complication for Peter to consider. Immobilisation and disuse is associated with reduced bone mass, and in spinal cord injuries, the main finding soon after onset is a reduced osteoblastic activity level, which results in bone degradation. This causes osteoporosis, brittle bones, and increased risk of fracture. Thromboembolic complications occur as a result of paralysis, trauma, hypercoagulability, and immobilisation. The risk of thromboembolic disease reduces with time, and the highest risk period is within the first 160 days after injury. This means that Peter's risk is reduced, however it is still higher than the average healthy population. Peter has also experienced some slight mobility complications in his shoulders. These are caused by muscular imbalances resulting from wheelchair movement. Studies have shown shoulder pain to be common in wheelchair users, and physiotherapy programs should be used to help avoid these issues. It is important to also consider other complications that can be caused as a result of spinal cord injury. These are conditions separate to physiological changes such as emotional and financial well-being, quality of life, and the patient's independence. In males, the age of a patient or the process of aging can cause increased fatigue, reduced activity level, reduced financial security, and an overall reduction in health and wellness. These are important considerations in Peter's case and should be planned for from an early age. So what is the significance of Peter's BMI and how could you intervene? The BMI is a standardised measure that provides a marker of obesity and a predictor of coronary heart disease in able-bodied populations. It is important to understand how the BMI relates to those suffering from paraplegia before making a full assessment. A number of studies have warned that the BMI scale does not accurately estimate obesity in spinal cord injury patients and will tend to underestimate obesity levels due to the fact that these patients tend to have more fat mass and less fat-free mass than the normal population. These studies suggest that it may be more appropriate to lower the obesity score for spinal cord injury patients, or if available, a DEXA scan will be a more accurate method of analysing body composition. It is important to keep these findings in mind when considering Peter's BMI. Peter has a BMI of 32 kg per metre squared, which places him in the obese category of the traditional scale. Given that a primary cause of mortality in spinal cord injury patients is respiratory and cardiovascular disease, it is important that Peter implements strategies to reduce his BMI and improves his body composition. Compounding these risks is the fact that apart from performing daily activities of living, Peter lives a fairly sedentary lifestyle. There is an increasing amount of research that indicates that living a sedentary lifestyle poses serious risks to health and is a modifier risk factor for the development of coronary heart disease, hypertension, stroke, cancers, type 2 diabetes, and osteoporosis. These risks are associated with extended periods of sedentary behaviour and can be reduced through increasing daily physical activity. To reduce the risks posed by Peter's increased BMI and physical inactivity, it would be beneficial to implement a daily exercise and nutrition intervention. These interventions would be based around structured patient-centred programming and patient education. A physical activity program would aid in increasing cardiorespiratory function, and a nutritional program would aid in reducing adipose tissue and improving lipid profile. Finally, Peter is concerned about autonomic dysreflexia. So let's look at how it presents and what acute management involves. As mentioned earlier, autonomic dysreflexia is a common condition caused by spinal cord injuries, which can have serious consequences if not addressed. These consequences include intracranial hemorrhage, retinal detachments, seizures, and death. So how does autonomic dysreflexia present? Autonomic dysreflexia is not always easily defined, as signs and symptoms will vary between patients. Many studies consider it as an increase in systolic blood pressure by at least 20% from baseline readings, with heart rate disturbances, and with at least one of the following: sweating, chills, piloerection, facial flushing, headache, or blurred vision. Management of autonomic dysreflexia is based initially on preventing episodes through the prevention or elimination of triggers. Autonomic dysreflexia is triggered by noxious stimulus and commonly through an overfull bladder. With this in mind, education of the patient on common triggers and a suitable time to bladder voiding strategy will be effective in reducing the occurrence of episodes. The acute treatment of an episode of autonomic dysreflexia is important, and early identification of signs and symptoms is crucial. Most spinal cord injury patients will be familiar with how it presents in their case and are able to detect it happening. Those in the acute phase of spinal cord injury are less familiar with symptoms and may take longer to notice them. So Peter, having had it for 9 years, should be fairly familiar with his symptoms and should be able to detect when he has an attack coming on. To treat an episode of autonomic dysreflexia, the following steps should be taken. As blood pressure is elevated, the first move should be to sit the patient upright, which will produce an orthostatic reduction in blood pressure. Should remove any tight clothing, including belts, collars, or compression garments. Should monitor the patient's blood pressure where possible, and you should treat bladder or bowel issues. In Peter's case, he has complete control over bladder voiding, and this may assist in the acute treatment of autonomic dysreflexia. It is important to remember that through medical advances, those living with paraplegia are often able to remain fairly independent. It is important to consider their new risks for developing cardiovascular diseases, and as such, preventative strategies should be put in place to ensure the patient remains as fit and healthy as they can. Thanks a lot for watching my video. I hope you enjoyed it.